Hi, this is Jenny Langley, author of the new Maudsley training manual. This video is about exercise 7.7, which is thinking about the concept of reasonable risk. So it's very difficult when families have been frozen and paralysed by the eating disorder, maybe for many years, and they're trying to think about moving forward, letting go, making changes, and both the carers and the person with the eating disorder can be completely stuck. So that's why we look at this concept of what is a reasonable level of risk when you're thinking about making changes. So often within the workshops, carers will ask things like, should I let my loved one go back to competitive football, to rugby, to cricket, to hockey, lacrosse, athletics, or any of the sports? Should I let my loved one go back to horse riding, rock climbing, dancing, fell walking, parties, festivals, holidays with friends, travelling on their gap year, and of course going back to school, college, university, getting a job, learning to drive, all of these things where you've got to think about this element of reasonable risk. So there's 4 questions that can be really useful to think about. So what happens if nothing changes? So no risk is taken and the person with eating disorder is not allowed to move on to the next level. And then what is the worst thing that can happen if we make these changes or we let these changes happen? What is the most likely thing that will happen? So it's not likely to be the worst case, is it? And then considering all of that, on balance, am I or are we prepared to take that reasonable level of risk? So the example I always give was, should we let our 12-year-old son go back to playing football 2 weeks after he's been discharged from the inpatient unit? And we had this kind of interesting conundrum because it was compulsive exercise that had made him very ill, and the inpatient psychiatrist was absolutely risk averse. She didn't want to let him play football. She said, no, it's far too soon, he shouldn't play football. The outpatient psychiatrist was much more, Jenny knows what to look out for, and so you should let him play football. It was always his passion before he became ill. And Jenny, you know what to look out for, so you can step back in if risk is getting too high. And these 2 psychiatrists were married to each other, so it was quite an interesting kind of concept. But I've since realised that the inpatient psychiatrists are much more likely to be risk averse because they don't want the young person back, whereas the outpatient psychiatrists are much more thinking about helping the young person to get back on with their life. So we did let him play football. So he went on several football courses over that summer. He really enjoyed them. And we gave him responsibility. We said, it's up to you, Sam. If you want to go back to football every day, you need to show us that you're able to feed your body, that you're able to, adjust, eat more when you need to, and ask for help if you need to as well. And he did. So he ate a huge amount to make sure he could keep going back to football every day. And he had a really, really good time. Okay, so that's just one example. Now, we can adapt these questions for a scenario in which the current status quo is deemed too risky. So this often happens at the later stages of recovery. So say, again, a young person might have been discharged from the eating disorder unit, and you might see that compulsive exercise is starting to creep up, or snacks are disappearing, or meals are becoming a bit smaller. And so the risk is, if you don't step in and take back some control as a carer, then is the eating disorder just going to take over? So the questions can be adapted. What happens if no risk is taken and the carers step in and stop all activity? What's the worst thing that can happen if this level of activity continues? So if the person continues to do more exercise and eat less, what's the most likely thing that will happen if this level of activity continues? Maybe it will level out. Every case is unique. And then on balance, am I prepared to take that level of risk and turn a blind eye to these kind of creeping signs that maybe the eating disorder is sneaking back in? And sometimes it just takes a bit of trial and error for the person to get it right. So there might be a relative energy deficit, but it might not be to do with the eating disorder. It's just that the young person is still trying to work out what the right level is. It's not easy always to know. So let's have a look. So an example of that might be, a carer might say, my 17-year-old daughter is becoming more active, she's cutting down on her snacks, she's definitely losing weight, albeit slowly, she's fiercely independent, so she doesn't want her mum involved. So mum's saying, should I intervene or should I let her work it out on her own? And again, it would be case-by-case basis. So let's have a look at a couple of examples. So going to university is a really good example, isn't it? So let's first of all look at a relatively low risk situation of a person recovering from an eating disorder going to university. So Sam, age 18, has been discharged from the adolescent eating disorder service. he has completed his refeeding program, he's had a course of cognitive behavioural therapy, his weight is pretty stable. But his mum and dad have got mixed views about going to university, especially as he wants to study sports science. So he's going to be quite active when he goes to university. So on the one hand, of course, they want him to get on with his life. And on the other, they're really, really desperately worried that he will relapse. Sam is really fed up with this, pushing back, saying, stop treating me like a baby. So what happens if no risk is taken and his parents say you're not ready to go to university? So it's likely that Sam will feel his parents don't trust him. He's likely to feel very angry, furious, and this might trigger a relapse in itself. He's likely to feel sad, lost and lonely if all of his friends are heading off to university. And the rest of the family will find that they're treading on eggshells around a very angry, sad, lost, lonely boy who simply wants to get on with his life. Okay, so that doesn't seem like a good option. What's the worst thing that can happen if Sam is allowed to go to university? Well, of course, he might have a relapse. You know, it's a big change for people, isn't it? Big first step away from parents. So if he has no support network around him, then he could have a significant relapse. So the key is to make sure that there's that support network around him. And what's the most likely thing that will happen? Well, most people who go to university in the later stages of recovering from their eating disorders do very well. So there was a survey, I think, that Beat did recently where they said about 60% of people who go to university with eating disorders do just fine. And then 40% might have to have time out, so they might dip in and out, but then complete their degree maybe at a later stage. Okay, so the most likely thing is he really enjoys the independence, he enjoys university life, he's motivated to look after his nutritional well-being and emotional well-being because he's really loving being in that environment with his peers, studying sports science. So on balance, can we take this risk? So we discussed this in a group setting and the group agreed that Sam should be allowed to go to university, but there should obviously be the same normal planning that you would have with any young person. And the parents could use any of the motivational techniques. So it says use oars here, but you could use any of the techniques to open a conversation with Sam to make sure that he's properly prepared and he knows what to do if he's struggling. So does he have a GP? Does he know about student wellbeing? Is he happy to sign the letter that the university can contact mum and dad if they need to? All that sort of thing is just sensible pre-planning. So let's have a look at a very similar example, but a more high-risk situation. So Sam has been discharged. He wants to go to university to study sports science, but unlike the previous example, he's lost weight consistently over the last few months, but is in total denial that there's a relapse, so he won't communicate. His parents suspect his BMI has dropped all the way down below 15, and they're really worried about him. Okay, so this is a really, really different scenario. So what happens if no risk is taken? Well, the same things as in the first scenario, so the loss of trust, the feeling angry, lonely, lost, all of those things, so that would still happen. What's the worst thing that can happen? Sam might lose more risk, and his medical risk is already quite high, so he could very, very quickly fall into a really, really unacceptable level of medical risk, and then obviously he's away from home, so that would be very risky. And of course, if he's participating in lots of sport, using lots of energy, has chaotic eating and sleeping patterns, is out at parties drinking alcohol, then he might be at high risk of collapsing. So it's a very different scenario. So it seems like the same, but it's very different because the risk is so much higher. So what's the most likely thing to happen? Well, given what we've just experienced with his rapid weight loss and his BMI being below 15, it's quite likely that that will carry on if he goes to university. So what's the best thing for this family to do? So again, we talked about this within a group, and the group in this case decided Sam probably shouldn't be allowed to go to university unless he agrees to get some professional help or a dietitian or nutritionist, or he starts to make some progress between now and then. So say there's 6 months before he goes to university, there's an opportunity for Sam to turn the corner, to re-engage maybe with, whether it's with the meal plan or some additional therapy or whatever the input is, that he can really show his parents that he's able to take back control from the eating disorder and start to improve his emotional and physical health before that day when he goes off to university. And you might want to look at the videos around the nutritional risk ruler where there's a similar example. Okay. Right, the third scenario. So again, this is one, so not going to university, but it's a similar one to the last one, where the eating disorder behaviours are creeping back in. So Amy's 20, she has anorexia, she discharged herself from her inpatient treatment a few months ago. In treatment, she did gain weight and she learned a huge amount about her illness. Since coming home, she's decided to defer university. So she wants a good year at home to be able to kind of carry on and reset herself. But she's currently working in a garden centre, doing 10-hour shifts for 4 to 5 days a week. So the last month, she's lost about ½ kilo a week. So her mum's really, really worried and is wondering whether it's time to step in and take over. Amy was seeing a therapist, but that's kind of fallen by the wayside. But she's now thinking about engaging with a peer mentor. So very often people in their young people in their early 20s don't really want to go back to a therapist if they've been in an inpatient setting, but they might engage with a coach or a peer mentor or something like that. Okay. So if no risk is taken, so in this case, the no risk would be Amy's mum steps in and stops her carry on doing the job. So similar to last time, her parents, she feels they don't trust her. She's likely to feel very angry and that might escalate a relapse. Again, sad, lost and lonely because the job at the garden centre has given her so much in terms of being with people and feeling valued and feeling that she has an identity. And again, the rest of the family treading on eggshells. What's the worst thing that can happen is the weight loss continues quite rapidly and Amy has a significant relapse and then might end up having to go back to the hospital, which none of them want. What's the most likely thing to happen? That's a difficult one to assess at this stage. So Amy's still at home, so she's got that safety net. But if the weight carries on going down, then she's going to get herself into trouble, isn't she, with her deterioration. So maybe if they can find a peer mentor who Amy really engages with, that can help to stabilise Amy and then she can start to kind of make up that lost ground gradually. And we know she's got a whole full year before she wants to go off to university. So on balance, so again, we've discussed this in a carer workshop, the mum decides she can't turn a blind eye, so she needs to step back in. Amy doesn't want her to step back in, but she needs to step back in. And by stepping back in, that means having a conversation with Amy. So addressing the elephant in the room and not, being really, really positive about how far Amy's come and everything that Amy's achieving, but just saying, look, we have to sit down and just weigh up what's going on here and help you to kind of get back on track. Also, it can be really, really helpful in this situation for carers to be looking forward and being curious about their loved one's future desires. So if Amy wants to be going on holiday, what she's going to be studying at university, all the other things that she's going to achieve, if she can maintain her physical and emotional well-being throughout the rest of the year and then be back on track in order to go to university, which is kind of her first real step to independence. Okay, so learning from this, so it can be really, really hard for carers to know when to take a step back and when to step back in. So it's like a balance, isn't it? If medical risk is high, you step back in. If medical risk is acceptable, you can start to step back. It's a fine balance. So carers can be tempted to be overprotective, like the kangaroo caring style, if their loved one is wanting to go off and do lots and lots of different activities very quickly after their recovery or to the tail end of their recovery. And also carers can feel that they're being asked almost to turn a blind eye when some of the eating disorders, so the ostrich-like behaviour, when some of those eating disorder behaviours might be creeping back in. So you can really use this model in either of those situations. So maybe think about a scenario in the past when you have been risk averse. So you as a carer have been risk averse because you fear that making a change will make things worse. And how did your loved one respond? Think of a scenario when you have taken a risk and it's been okay. And what were the things that made it okay? Was it that pre-planning? Was it having a safety net and a backup plan? Was it knowing where to go in a crisis? Maybe think of a scenario where you have taken a risk and it's not worked out so well. So what could you learn from that? What could you have done differently? What would you do differently next time? So pre-planning, visualising, verbalising, and contingency planning can considerably reduce the risk of any major setbacks, whatever is going on for your loved one as they go forward in their life. By you making changes, so by you taking reasonable risks, so whether it's stepping back or stepping back in, so consider when it's stepping back, you're showing that you believe your loved one is ready to take more responsibility. We all learn by taking risks and making mistakes and learning from those mistakes. Taking risks, of course, is a normal part of life. Remember that if nothing ever changes, then nothing ever changes. You get stuck in a cycle. So lots of families feel that they're really stuck with eating disorders. And we know that change is uncomfortable for everyone. And it can feel like things get worse before they get better. So it's being able to tolerate the distress of that sometimes when that happens. Okay, so I hope you found that useful. All of the videos are on the website with the different worksheets. And I hope to see you soon.